First of all, try to think out of the box. There are many interdisciplinary problems that may be solved with a plastic surgical technique.
Was there somebody in your career early on who gave you that courage, who gave you that confidence in yourself?
Thank you, James. This is the best question.
Welcome to the next episode of The Rest is Plastics, with me, your host, Anton Fries.
And me, James Chan.
Today, we're speaking to a towering figure in the field of plastic surgery, Dr. Milomir Ninkovic. Professor Ninkovic graduated in 1982 from Sarajevo Medical School, and he was trained by the legendary Marko Godina in Ljubljana. His first consultant post was in Innsbruck in 1992, and for 20 years, he was the head of plastic surgery in Munich. He now is the senior plastic surgeon at his private clinic in Croatia. We spoke to him about his latest paper in JPRAS.
And this paper is the latest of his string of innovations that really impacted plastic surgery. So this paper is called Free Functional Gracilis Muscle Opponensplasty for Thenar Reconstruction. So this is to replace the function of the thenar muscles in people who've had injuries to the hand, but with a recurrent motor branch still available. It's a really fascinating technique. I can already think of 2 patients who can benefit from this in my own practice, so I can't wait to speak to him.
Dr. Ninkovic, welcome to The Rest is Plastics. We're honoured to have you to join us today. We're going to start by talking about your most recent paper in our journal, which is Free Functional Gracilis Muscle Opponensplasty for Thenar Reconstruction: Indications, Technique, and Long-Term Outcomes. It's a great paper, and we really enjoyed reading it, but perhaps you could explain to our listeners, why you chose this topic to write about.
First of all, thank you very much for the invitation. It's a great pleasure and honor for me to be together to you in this podcast and to discuss about this paper. I think in my career, it was always very interesting if you get some challenging, demanding case, you will start to think a little bit differently. And always in those cases, I will tell my residents, you should define the 3 problems. First, it's the reconstructive problem, to define the anatomical deficiency. And when you define this reconstructive anatomical deficiency, you should think about the functional deficiency. And of course, at the end, you should think about the aesthetical point of view. And if you look at this case, the first case, what I get, he doesn't have any thenar muscle. He has the closed first interdigital space. It means you have to reconstruct the thenar muscle, and you should reconstruct the first interdigital space. Using traditional technique, taking Opponensplasty or something like that, you do not have a good soft tissue coverage. It means I'm supposed to bring in one surgery everything what I need. And I will always put on one side requirements, on the other side the possibilities to get that. And I noticed actually his median nerve was intact. It means the motor branch of the medianus was intact, and you can find it. And I thought it will be the good case now for the functioning Gracilis free flap. And after analyzing everything, we went to the operating room and actually performed this surgery the first time. It was not experience about this procedure. And of course, I have been doing a lot of functional muscle transfer. And I know taking the care about resting muscle tension, taking care about how to put the strap muscle form of the gracilis muscle to get a good opposition, because the main point was to get opposition and to open the first interdigital space. And I put the muscle in the first interdigital space, open that, and after that, at the end, I make the coaptation of the motor branch of the thenar motor branch with the motor branch of the gracilis muscle. And this is actually why I decided to go to this procedure, because I wanted in one stage surgical procedure to get the full reconstruction.
And just for our listeners, this first case you were talking about, this is the 26-year-old woman who had a burn injury, is that right? Then she developed compartment syndrome.
Exactly. And she was operated before that, and they take distally based posterior interosseous flap, but to open just the space, interdigital space. But the flap was so small that they were not able to open the space. And if you open the space, you do not have the function, because you do not have the movement, and you have to think about some opponensplasty taking some of the tendon, available on the hand. But I wanted actually to find a solution in one procedure to solve all reconstructive, functional, and aesthetical requirements in once.
And then you had a second case. Can you tell us a little bit about that one too?
The second case was more difficult because the second case lost one hand because of the explosion, and carpal metacarpal joint was not working very well, and he had a problem with a flexion of the distal phalanx because he doesn't have any flexor. And I thought, okay, what I can do, I will perform the same procedure, taking the Gracilis, putting the silicone rod in the position of the flexor pollicis longus tendon, and in the second operation, I took just from the amputated finger, I took the superficial flexor tendon and transposed actually to the thumb to get a good functioning thumb. And this is something what you can combine, in the first operation, you solve the main problems. In the second, you improve actually the flexion of the thumb because he was having just a part of the one hand.
That's great. I suppose I'm a part-time hand surgeon, but I think there are three muscles in the thenar on the front. You have flexion, abduction, and opponents. How do you place or how do you inset the gracilis to mimic all three of those functions? Do you have to prioritize one over the other? How can you explain to us, how we can? There's a lot of detail in the paper about where you've inset the muscle, but how do you achieve that?
You are absolutely right. You couldn't achieve all the functions, but you have to put the priority. And the priority is, of course, to get a full opposition. And you will combine with some kind of abduction and opposition. And I went with the muscle to fix it to the all tendons, remaining tendons, actually, the insertion of the tendons of the thenar muscle, to get the full scarring in this area. And this scarring actually will pull all the thumb in the opposition and abduction. Of course, adduction you couldn't get so good because you have the muscle in between, but adduction of the thumb is not so important like abduction and opposition of the thumb, opposition with the other finger. You wait for 3 months to get a really full function. Therefore, you are getting a really appropriate scarring at the place when you put it together.
If I may just go into a bit more detail, do you open up the whole thenar eminence? You take out, you do a debridement, and then you see what's going on to see whether the thenar branch is there before you commit to raising a gracilis?
You're absolutely right. There were no any debridement because it was scarring tissue, And it means I will open the carpal tunnel. I will go straight ahead to the median nerve, follow the median nerve from the carpal tunnel distally, and find the motor branch. And when I define the motor branch, we will start to raise a gracilis muscle flap, because I was not absolutely sure that I will find intact motor branch. And after that, you will remove actually all scarring tissue to get a full opening of the first interdigital space, because you have a contraction of the interosseous muscle, you have the big scarring there, you have to open that really to get the 90-degree opening. And after that, you will, after removing that, I always go with this radical, as you told debridement, but radical scar release, actually. And after that, you will put the healthy tissue in and to try to get optimal function.
And you had a great bit in your paper where you talked about measuring from the distal carpal tunnel onto the head of the first metacarpal, just to measure that distance, about 10 centimeters, I think, for one of your patients. And then you talked about marking that with the gracilis in situ, so that you can set the tension right. Can you talk a bit about that?
You know, in all the functioning muscle transfer, you have to think about the resting muscle tension. And resting muscle tension is actually the length between the insertion and the origin. And always when you raise this functioning muscle, you have to put the thread. You have to fix every 5 centimeters or 10 centimeters, independent how long you need your muscle. You have to put the thread, because when you raise the muscle will contract significantly. And after that, you have to restore this length of the muscle between the new origin and new insertion to get a fully functioning muscle. If you don't do that, I always show that like that. If you have the muscle fibers like that, and you didn't do that, and the muscle fibers are shortening, you know, they will never get a good function. You have to put it back in the proper position, anatomical position, that they can contract and bring you the new function, what are you asking for.
One more question about the inset then. When you insert the muscle, I can understand it inserting the proximal origin of the gracilis onto the distal carpal tunnel, because you've got kind of gristle to gristle. But when you've taken the 10 centimeters, you're now sectioning the muscle fibers themselves. How do you then insert muscle onto the kind of scar that's left there, the muscle insertions of the native muscles?
This is a very good question, you know. Always when you are raising the muscle, you will try to take the perimesial. This is the part outside of the muscle, because the perimesial is only the structure that can hold your stitches. And you are not allowed to do it with one stitch. You know, I will go once through, coming back, and again once through, to have actually two threads with one tightening. In these occasions, there is no any rupture through the muscle, because you have to avoid the rupture through the muscle. Otherwise, you couldn't get the muscle fixated very good. The second point, if you have those problems, you have to put the one stitch transversally on the muscle. And after that, go back from this transversal stitch to keep actually the good tension of the muscle. And I did a lot of this, functioning muscle transfer, and exactly we try to find the best solution how to restore this resting muscle tension.
And so it's almost like a tendon repair.
Exactly, like the tendon repair, that you are putting the transversal stitch, and after that going back to fix it, that there is no rupture through the muscle.
Right. So if you want to keep the muscle stretched and elongated so it doesn't contract like you said, then post-operatively, do you have to splint the thumb in a good position so it's extended or not?
You don't need it. You don't need it. You will actually put the thumb in some relaxing position to get it healed. And after that, you will try with a passive training, making the distension, elongation, and everything, because the muscle is healthy and the muscle will elongate in the proper position.
And any strains or anything?
Of course, yeah, I will put a very small drains if I expect some bleeding. You know, this is really. But I will generally make a full abduction of the finger, full abduction of the finger. Make actually this fluffy bandage, you know, very light, fluffy bandage, and keep it for the longer time to get it good healed. First of all, because of the skin grafting. And the second of the good positioning of the thumb.
Anton, over to you. Sorry, I hogged it.
That's fantastic. I really got in the details of the methods of the procedure. Moving on to the results, you mentioned 3 months for the outcome. Is that completely linear? How does that look, and what sort of function did these patients end up with?
I will tell you something, because this is a very short distance of nerve regeneration. And after 3 months, they will start to move the gracilis flank, you know, and you will see, but you're not getting the full opposition. But you would like to get a first movement of the gracilis, knowing that the ingrowth of the muscle and muscle regeneration or the reinnervation is started, and you can get it really after 3 months, much faster than you are getting normally and the other extremity because the distance is longer. Here is the distance very short. And I will try, for example, to cut my motor branch of the Gracilis very close to the muscle to avoid actually longer recovery time and regeneration time.
No need for functional electrical stimulation, anything like that?
I don't use it. I have been using since 35 years functioning muscle transfer. I don't believe strongly in it's a, I would say you should take your patient busy, but I don't really believe in a very stimulation, and we do it regularly, but I'm not really very sure that it works very well.
No shortcuts.
It's a very satisfying operation. Obviously illustrates all the principles of functional muscle transfer, nerve regeneration, and all in one, really.
Perhaps we can just step back a little bit, because we've talked so much about the nuances and the techniques and so on, but should we just talk about the indications? Because this is a group of patients who could have an opponensplasty, the traditional form, but this is also a group of patients who happen to have a functioning recurrent motor branch still available.
Exactly.
And that's not many patients will have that.
You're absolutely right. If I wouldn't have, for example, the motor branch, I will tell you, I will take extended lateral arm flap to make the first interdigital round nice, and in the same time, I will make the classical opponensplasty. It doesn't matter which tendon you will use, but anyway, you can combine that. Why extended lateral arm flap? Because this is innervated flap, and the patient will get a very good sensibility, and you have a great coverage, and you will do the classical tendon transfer. But this is more exciting, with Gracilis as a functional muscle transfer.
But also with the benefits of, it doesn't require cortical plasticity, the relearning.
Exactly. This is true. Re-education, what those patients need if you are doing a classical opponensplasty.
Perhaps age would be an important factor in deciding who would be a good candidate.
You're right, but I will tell you, very surprising in different cases. I did, for example, lower lip reconstruction in the age of 75, using the innervated Gracilis for the lower lip reconstruction. And the patient are able to whistle after this reconstruction. It means because you are having the very short nerve distance to regenerate and to reinnervate the muscle. Therefore, in those cases, if you need now long distance for reinnervation, it may be for the elderly patient, it's not the best option. But if you have a very short distance for a nerve regeneration, you can use it in elderly patients without any difficulty.
I think, let's move on from the paper. It's been wonderful to speak to you about it. I mean, I think I first read your paper on deep flap angiosomes almost 15 years ago, and recognized you as a pioneer and innovator in plastic surgery, for the whole of my career, certainly. And I know you've been from Croatia to Munich and sort of back again, and other places in between. While we have you speak to us today, perhaps you could, what of your many innovations, what are you perhaps most proud of, or what would you like to tell our younger listeners about?
The younger generation, I would like to tell two things. First of all, try to think out of the box. And if you learn and prepare your exam, I did it always, you will find a lot of new ideas. You should write it down, put it on the table, and to wait. And one day you will get maybe those patients. I will tell you the story of one of them. I did a lot of emergency free flaps at the beginning because I was the fellow of Marco Godina. And I put, in the very early 80s, I put the on my table, I will use the E-step free flap if I get the case with the palmar defect. And I did it in 92 and published in 95 in PRS as a New Ideas and Innovations. This is something what I would like to set for the new generation. But I'm very proud of my first big publication in British Journal of Plastic Surgery in 94, when I introduced the nerve transfer and the muscle transfer for drop foot surgery. Because learning as a young specialist that you are having the synergism in the function if you do the tendon transfer on the hand. You're thinking always about the synergism in the function. And I was trying actually to make this synergism on the lower leg. Therefore, I need a nerve transfer, taking a deep peroneal nerve to the motor branch of the gastrocnemius and transfer the gastrocnemius to the anterior side, getting out actually the normal walking pattern. Today, this procedure is all over the world. We had one discussion just a few weeks ago of the people who have been doing this procedure, and they are so proud because you are getting a normal walking pattern. This is something what makes me very proud of this procedure. The second one, it's, I think, amazing, the reconstruction of the lower lip. You know, the group from Taiwan, they introduced anterolateral thigh flap with the tendon and something. And I put the Gracilis free flap, and my patients are able to visit. It was one of the best cases presented at the Marco Godino lecture, what I gave in Palm Springs at the meeting, you know. And this is something what you can really improve the quality of reconstruction. And after that, actually parallel to that, I did abdominal wall reconstruction using innervated LDM flap. It's still, we do a lot of those cases, and especially if you have a huge full thickness abdominal wall defect. But according to this experience with abdominal wall reconstruction, we introduced one technique in 90s experimentally and later on the patient, making latissimus dorsi detrusor bioplasty. For the paralyzed urinary bladder, we are using the innervated LDM flap to replace actually the detrusor. And it is the first clinically applied technique for the organ reconstruction. But again, synergism in the function, you know, because if we go to urinate, the urinary bladder is the only organ that we can control with our brain. We will go to urinate, we will contract the urinary bladder, and therefore I took the intercostal nerve supplying the rectus abdominis muscle to make actually innervation of my LDDM. We published that in Lancet in 98, and after that I think we have more than 70 cases now in these years, and there are some other institutions doing the same. And this is something what makes me proud, you know, to do something quite different, innovations in different fields. And I would like to say the new generation, you know, there are lots of interdisciplinary problems that maybe could be solved with a plastic surgical technique, but we don't know that. And we have to really discuss with our colleagues, because I didn't know anything about urinary bladder, paralyzed urinary bladder, but I met the urologist who explained me and became my best friend, who explained me this problem, and we started to work on it. Therefore, for the young generation, please talk to your colleagues, interdisciplinary, and I'm sure you will find a solution to apply your technique in many different problems they're not able to solve. For example, I will tell you another one example. I did a sternum turnover free flap for the pectus excavatum, funnel chest. And I do it with now with a cardiac surgeon, because you have it always in Marfan syndrome. And the cardiac surgeons are very happy because you are opening the thorax, taking the flap out, you are making remodeling of the flap. They can do the cardiac surgery, finish that, and they don't need to put it back. You will put it back for them. And they're so happy because they're spending half of the time in the operating room and in combination. And this is now standard technique in Munich, for example, in our Center of Cardiac Surgery. We introduced this in 2005 there, and they do it because it's a really good combination between two procedures, and the Marfan syndrome does need actually this surgery. This is something what I'm talking about. The future of the plastic surgery is really cooperation with other disciplines to find what would be the best indications for us and what we can help.
Well, it's so inspiring to hear all that. But you make it sound so easy. It's so much more than just having a curious brain and looking for problems to solve, isn't it? I mean, when you're doing some of these things for the first time, there must be a lot of skepticism. There must be a lot of pushback. How do you build that resilience and to convince people that this is the way forward?
I think, again, getting back to this analysis, you really have to analyze everything. As I told, requirements, reconstructing functional. And after that, to make a very appropriate plan. The planning, I think, in my life is the most important part. When you have the good plan, you can do that. But you have to know the plan should be based on the principles of plastic and reconstructive surgery. No experimental thinking, everything has to be based on the principles. And if you do that on the principles, but on different way, functioning muscle transfer is one of the most possible technique, but it works. But to apply that properly, you have to know all the rules how to do that. And I think this is the main point, is the analysis, plan, and performance. And if you do something first time, I will tell you in my experience, when we did the first time bilateral hand transplantation, allotransplantation, the main point, what I can see now in the presentation, is the balance actually between the extensor and the flexors. And I told my team, look, we have to work that. We need to reconstruct the hand cascade. Otherwise, you will never get a good function if you do not have this balance. And this is something in the preparing of this procedure. Because technically, hand transplantation is easier than hand replantation because you are not missing anything. You have enough tissue. But the planning, it's the main point, in my opinion.
Also, I think that the trust that the multidisciplinary team will have in you is something that you've had to earn by showing these results and, as you say, these foundations and principles. And then over time, you can start to, based with that foundation, you can start to innovate with your colleagues.
You are absolutely right. Again, one story, what's happened to me. I was in Innsbruck in that time. It means it was about 98. And the transplantation surgeon came to me with a child of 7 years old, having the second bone transplantation and having a huge defect on the abdominal wall. I look at the child and I told, I have solution for him. He looked at me and thought, this child will die because there is any coverage of that. Taking immunosuppression therapy. I did this functional latissimus dorsi flap. Everything healed primarily because you are bringing always, this is the main point in the surgery, healthy tissue, did the appropriate debridement, having around the healthy tissue, and only healthy tissue will heal with the healthy tissue primarily. It doesn't matter if the patient has immunosuppression therapy or not. Because I did many of those cases when I was in Innsbruck, and it works very well in those cases, It means generally, if you follow the principles of surgery, you can achieve those results. And if you achieve this result with the general surgeon, they will appreciate your opinion, they will appreciate your work, and they will let you do many other things, This is something what is for me, the first contact, you have to make clear your position and to tell, look at, this is the way how we can make it, and I can guarantee you that it will work.
And just one more thing, you must have enormous courage and confidence in your own training and your experience. Was there somebody in your career early on who gave you that courage, who gave you that, confidence in yourself?
Thank you, James. This is the best question. I will tell you something. I was all my life very happy because I met Marco Godina first as a main guy who gave me the principles, gave me the knowledge. They gave me inspiration and motivation to do the things. After that, I moved in Innsbruck, stayed for 11 years, and met Hans Ander, who was amazing surgeon, guy who was craniofacial surgeon, showed me the craniofacial surgery, all those cases. And I was very lucky in the time of more than 20 years getting amazing education. And I think this is the main point, that if you get an amazing education, you become actually the confident in your work. And this is something what I would like always to emphasize from the very beginning. And I had a great education when I was in Sarajevo. We had the great mentors, great microsurgery department, and I started in '82. It's a long time ago.
Dr. Ninkovic, thank you so much. I think that was the best question, so that's what we'll end on.
Last question, because this is something what the young generation has to know. Choosing the best mentor is you are very lucky. You don't lose any time.
Phenomenal. Sir, thank you so much for your time. We're absolutely honored for you to join us on The Rest is Plastics, and enjoy the rest of your evening. Thank you.
Thank you. Thank you for giving the chance to talk to you. It was really a pleasure to talk to you. Thank you so much. See you. See you.
James, that was a fascinating conversation. Dr. Ninkovic really lives up to his reputation as an innovator and figure in our field. What were your main takeaways?
Well, so many things to think about. First of all, finding the right patients for this kind of reconstruction is it's not going to be easy. But in those who can have this, I think this will be transformative. We went through so many of the nuances on how to do this reconstruction. And I think this is not something that sounds as easy as he made it out to be. I think that requires a lot of experience and understanding on how functional muscle transfers work. I mean, he's had all his experience talking about the lip reconstruction and the dorsiflexion of the ankle and so on. So I'm sure all that experience would have come into this technique for the opponensplasty. How about you?
Yeah, well, I mean, likewise, it really is, I guess, the sort of pinnacle of a life's work in functional muscle transfer. I think perhaps more generally, this idea of, if you see a problem that isn't well treated by any area of medicine, let alone plastic surgery, make a note of it, and maybe one day you'll have this sort of light bulb moment and be able to fix it. And I think, I've heard something similar, people before, sort of, if you want to sort of innovate in plastic surgery, don't do something that everyone does. Find something that no one can do and apply yourself to a difficult problem. So but it's one thing to say that, but it's another thing to do it. So kudos to him.
Yeah, and looking at the references in this paper, actually, there have been a number of different attempts to solve this a similar type problem. So people have used pronator quadrators, pectoralis minor, and all sorts of different things. And I suppose the Gracilis is yet another potential donor site. But it does make sense that he's got the great excursion is one that we're all very familiar with, and has a great pedicle that can just slot straight into the local nerve and vessel supply.
Yeah, simple as that.
All right, next week.
Fantastic. Well, thank you so much for listening. Please like, subscribe, leave us a review, and consider submitting your research to the Journal of Plastic, Reconstructive and Aesthetic Surgery.
Until next time, the rest
is plastics.